Hello, and welcome to another episode of No Notes, where the conversation is a perfect 10 out of 10. This podcast is powered by Elios, the most used and most loved AI platform in behavioral health, equipping more than 130 organizations and tens of thousands of providers with powerful automation tools that streamline documentation, simplify compliance, and surface deep care insights that drive better clinical outcomes. I'm your host, Dr. Denny Morrison, and for today's episode, we are excited to be joined by Chuck Ingoglia, President and CEO of the National Council for Mental Wellbeing, and Guida, President and CEO of Guide Consulting Services. We'll chat about the current status of proposed federal changes and what they might mean for Medicaid funding, grant opportunities, and other critical aspects of behavioral health care. Chuck and Al will also offer their take on how behavioral health leaders can stay proactive and prepared for the road ahead. So, welcome, Chuck and Al. Thank you so much for being here today.
My pleasure, Danny.
Thank you, Denny.
Well, these are unprecedented times. In prepping for this. It just happened that I heard a John Lennon song called "Nobody Told Me," and there's a line in it that says, "Nobody told me there'd be days like this. Strange days indeed." I think that accurately encapsulates kind of where we are these days. So, Chuck, why don't you kick us off a bit? Tell us a little bit about bring us up to speed on what's happening on the Hill and from a policy perspective.
Yeah, thanks, Danny. Well, maybe I'll just take a step back and just reflect a little bit about both Al and I have been doing this kind of work in this particular field for a long time. And I would say, as I think about my 20 years at the National Council, probably one of the biggest changes I would comment on is how bipartisan our issues have become, issues related to both mental illness and to substance use disorder. 20 years ago, that was not the case, right? And I think over the last few years, we have seen, just tremendous progress on a bipartisan basis for things that our field cares about. Certainly, when there was unified control of Congress and the administration, we knew that there'd be some challenges. But I would say the challenges that we've seen so far in these first 100 days have gone well beyond anything that we imagined or contemplated. And, I can say have been very unsettling, for the National Council. And as I talk to our members, certainly unsettling for them as well.
So just to build on what Chuck indicated, I really do think it is. And sort of for two specific reasons. Number one is the grant cancellations, right? So during COVID, and specifically during the Biden administration, there was a large amount of money that was provided specifically to the mental health block grant and the substance abuse and prevention treatment block grant. There was about Denny, $1.3 billion worth of fee and unexpended monies that were still available to the states. States had until September 30th to spend that money, and the administration terminated all those resources on March 24th. So that caused anxiety, alarm, shock waves in the mental health and addiction treatment community. And then secondly, and again, we'll get into this in greater detail, is this reorganization. Essentially, the arm of the federal government for primary care and the arm of the federal government for mental health and substance abuse have been combined into a single agency called AHA. And that is good and bad. So let me stop there.
But it seems like in the past, when we've merged behavioral healthcare into other general healthcare systems, we lose visibility. And this seems like it might dilute our positioning in the kind of the new regime. So, Al, is there good? You said there's good
Right.
news in here somewhere.
All right. So here's the upside. The substance abuse and mental health communities are constantly being preached to about the need to integrate with our primary care and medical specialty brothers and sisters. And so, in theory, this combination should provide an opportunity for this greater integration, right? So that's a good thing. Although, I mean, let's just be clear about this. If you just look at it clinically, right? When folks talk about integration, they really mean integration of care for individuals with major clinical depression, anxiety disorders, and some substance use disorders that can be served in a primary care setting. That's what they're talking. They don't mean it the other way, which is that primary care and specialty medical services need to be integrated into the mental health and addiction treatment setting. So for this to work, the integration needs to be both ways.
Yeah, when you look at the data on that now, you're spot on. We know that 50% of all mental health care in the United States is delivered by primary care physicians. Not particularly well because they got one tool, it's a prescription pad. So getting primary care providers to do more work with behavioral health providers, that's a good thing. So I agree with that part. But it's not just that. When people with serious mental illnesses are dying younger than their non-mentally ill counterparts because their primary care is terrible, that's got to be addressed too. So that is a good news, bad news kind of position. So the one effort that we've had most recently on that particular topic has been CCBHCs. What effect is all this gonna have on CCBHCs, guys?
Yeah, so remember that there are multiple streams operating to make CCBHCs a reality. One of which is the Medicaid demonstration program, in which now 20 states are involved, and other states have planning grants to bring that online. And so there's nothing currently being discussed that would directly impact the CCBHC Medicaid demonstration. And then also, SAMHSA operates a grant program for CCBHC readiness and/or to support existing CCBHCs. We had 2 weeks ago, Denny, was something kind of unprecedented. A version of the president's 2026 proposed budget was leaked, and we got a glance at some of the thinking coming from the White House in terms of kind of priorities related to the federal government. And I think that document indicated that lots of functions across the federal government would be proposed by the president to be eliminated or severely defunded, including 42 programs at what is now SAMHSA, including the CCBHC grant program. And so obviously we are working with the appropriations staff in Congress to try to make sure that money remains available. In general, the president's budget is a nice document that comes out once a year, and people don't really pay a lot of attention to it, especially appropriators. But this is not a normal year, and I do fear that the president's budget proposal will likely have more of an impact than it does historically, especially in the House of Representatives. So we're taking this very, very seriously.
Kind of hinted at this. What else is going on with Medicaid funding that people ought to be aware of?
Well, we're about to find out, Denny. Congress has initiated what is called a budget reconciliation process. Now, this is not to be confused with the annual appropriations process, and it has the word budget in it, so it's very confusing. But it's a particular type of legislative maneuver that allows voting to happen with a simple majority, and therefore not subject to the filibuster. And it's the main way that Congress will extend the 2017 tax cuts. The president has also indicated that he'd like to have more funding in there for border security and more funding in there for things related to the military. But at the same time, it will also be a vehicle then for cutting other parts of the federal government. And what ended up happening is that there was a resolution passed a few weeks ago that it gave different committees in Congress instructions either to spend new money or to cut money. And the committee in the House of Representatives that has jurisdiction over the Medicaid program, their direction was to save at least $880 billion over the next 10 years. And the $880 billion is a minimum, not a maximum. It's a minimum that they have to cut. It would pretty much be impossible for them to hit that number without taking money from the Medicaid program. Al, fill in there for me.
So $880 billion is 11% below current Medicaid spending. Sort of two things I want to say. So first of all, it's April 28th. They've been discussing this since January, and the House Energy and Commerce Committee will begin the process of examining the Medicaid program next week, Wednesday, May 7th. We're going to be at this for quite a while, probably well into June through early July. So this is typically a lengthy process. And then secondly, there appears to be kind of an inverse political correlation. The longer the process goes, the lower the number gets. So the chairman of the committee, Representative Guthrie, so he says, well, that the number has dropped now to 600 billion to 500 billion. And then rumor has it that the chairman of another committee, Jason Smith from the Ways and Means Committee, the Tax Writing Committee, told one of his constituents during the recess that the number is actually 400 billion. So there appears to be a sort of a political process where the longer the process goes, the lower the Medicaid cut number gets. And so that, I have to say, is an encouraging sign. I think the concern for the listeners of this podcast, Medicaid reimbursement rates for providers and uncompensated care caseload. These are the two specific things that leap to mind. This is what keeps Chuck up at night. This is what keeps me up at night.
Just imagine that your family's budget was cut by 10% or even 5%, right? You still have all the same bills. And so what do, right? You figure out, where can I spend less money? And that's exactly what states would do, right? And in most states, Medicaid is the single largest portion of state discretionary spending. And in the Medicaid program, there's basically three ways that you can make changes. One is you can make fewer people eligible for the Medicaid program. You can cut benefits, and or you can cut how much you pay for things. And all of those things, as Al pointed out, would have a detrimental effect, right, for people who deliver mental health and substance use care, and also for the people who need it, right? We already have an access problem in this country, and I think that will likely only exacerbate that.
And if you do any one or all of those things, if a state does that, the providers have to kind of respond in kind. They've got to make decisions about who they can and cannot provide care to, which
Of
means,
course.
in my mind, that means you're going to not treat people, which means those people will probably escalate and end up in emergency rooms. And the EDs don't have a choice to take whether they could take them or not.
Right, and we already have a problem in emergency departments around the country, right? Of unfortunately, right, those things usually take a while for those effects to be felt, and the time between something is implemented and when it's felt, it has the potential to insulate people from the effects of those decisions.
Yeah, well, and I got to believe the American Hospital Association is all over that. I mean, they know what's coming.
I don't know that many people contemplate the fact that lots of middle class families who have loved ones in the nursing home, that's being paid for by Medicaid. Lots of services for children in schools being paid for by Medicaid. And almost all half of the births in this country paid for by Medicaid. And so there's lots of people that will be affected by these kinds of changes.
I think stereotyping going on about what constitutes a Medicaid recipient, it's far, far more diverse than people imagine, and their loved ones and good friends are at risk. Regardless of what your political stripes are, you're going, there are people who are going to be affected by this.
Denny, this is spot on. And all I would say further, just again, build on Chuck's comments with respect particularly to the Medicaid expansion, which is 40 states have expanded the Medicaid program. Now, the good news here is that states are paid more than what they would typically get in Medicaid to provide Medicaid coverage. Medicaid is now a working class program. It doesn't have quite the support that Social Security does or Medicare, but it's kind of getting there. It's not quite a third rail, as they say here in Washington, but it seems to be getting there because of this Medicaid expansion that is covering working class Americans. It's making, in particular, Senate Republicans, conservative Senate Republicans. Josh Hawley from Missouri is nobody's
Liberal.
example of a progressive. Has has indicated strong opposition to cutting the Medicaid expansion. Prior to the Affordable Care Act, which made the expansion, if you just looked at chronic disease categories and nothing else in terms of insurance coverage, mental illness and addiction disorders had the highest rates of lack of insurance. And so today, my understanding is that about a third of the entire Medicaid expansion population across those 40 states have a diagnosable mental disorder or a diagnosable substance use disorder of various shapes and patterns. So our community has a huge stake in defending the Medicaid expansion for the health of those patients and for the health of the providers, right? Because it would be a financial calamity for residential treatment centers for persons with substance use disorders to have your uncompensated care caseload rise. Denny, you used to run one of these facilities. You know what the margins are. And man, our margins would be pressed in that kind of a financial circumstance. And so that's what the National Council, both individually and then in partnership with the Modern Medicaid Alliance, is fighting, are proposals like those that I've just described.
As people are listening to this, are they're nervous, like, reach out to your members of Congress. And, we have ways for you to do that through the National Council's website. And I think it's really important here because language is an interesting thing. So I think what you're hearing people say is like, we are not doing anything that will change coverage for people with disabilities. And while technically true, if you take money out of the program, you are in effect will actually change what people can get. I saw a great quote last week from an anonymous member of Congress saying, well, if we change these things, we're not cutting it because the states could continue it if they want to, right? And the difference, right, is that states have requirements to have balanced budgets. And I don't know many states right now that have huge pots of gold buried around the state capitol that they want to dedicate to the Medicaid program, right? So it's a little, I would dare say, disingenuous.
Well, it's kicking the can down the road. Let somebody else deal with it. But in terms of the dispersion of Medicaid throughout the United States, is it disproportionately used by red states? Do you either of you know that?
The way the Medicaid formula works, right? It's a federal state partnership, and states are guaranteed to receive a 50% match. And then it escalates from there depending on a variety of factors, including poverty. And so it is true that a number of red states get a much higher matching rate for their Medicaid program than quote unquote blue states do. So I think they would be hit fairly hard.
So let's take Kentucky, for example. Again, a third of the GDP of the state of Kentucky flows from the federal government through transfer payments, mostly Medicaid and Social Security. So, in the case of, let's say, Alabama, Mississippi, and Louisiana, the federal medical assistance percentage, which is what they get for every dollar of Medicaid spent. So in Mississippi, I believe it's 85%. So for every dollar of Medicaid spending in the state of Mississippi, the federal government puts up 85 cents. The state of Mississippi puts up 15 cents. So that's what Chuck was referring to. So they're very heavily dependent upon the Medicaid program because of the high levels of poverty in these red states. And in turn, they're very heavily dependent upon the program to finance. These are also states that disproportionately still operate fairly large public hospitals. And so as a result, depend upon state monies to finance those facilities. Yes, it's not an even playing field. So you find that oftentimes red state governors then will oppose certain specific Medicaid proposals because they're being hit in a way that they can't afford.
When we talk about conservative legislators coming to saying, "Wait a minute, I'm now concerned about Medicaid," it's not out of the goodness of their heart necessarily as representing their constituents, and that's okay. That's what they're there for. I'm not dissing that. I just for the audience, I want to say there's a reason why why this would happen, why these legislators might, at first blush, look like they would be anti-Medicaid, but they're not, and here's why. But let's shift. I want to get into the topic of what can providers, the members of NAMW, Chuck, what can they do for all this? I mean, geez, it's like I'm not even a CEO anymore, and this scares me. So I can imagine how my peers are doing with this.
Well, I mean, so there are, kind of like the traditional things that you could do, right? You can reach out to your members of Congress. You can participate in town hall meetings. You can meet with. You can come to Washington. You can meet with your staff back home. But I'd also just think like, who else cares about the work you do in your community, and how do you engage them? My experience has been law enforcement really benefits from and is generally supportive of mental health centers and substance use providers when they can, take nonviolent offenders and divert them from jail and really support them. Can we engage them? Chambers of Congress, business improvement districts. Who are people who might also care about what you do? And then the other audience that I think we've got to get more involved are the voices of people who receive supports and services from us. Because I think going back to what you were saying, Denny, there's like this idea of who these Medicaid beneficiaries are and really telling their stories, getting letters in the local paper, op-eds, running an ad. I mean, if you want to do, this is the time now to think broadly about how to take on these topics.
Al, you got any suggestions?
Yes. So this firm, Guide Consulting Services, represents a lot of clients in the mental health and addiction treatment space. When I get into a meeting or we get on the Zoom call with the clients, I typically begin by saying, don't panic. So that's the first thing I want to say to the folks listening to this podcast is don't panic. And then secondly, like the sense of chaos that you must feel at home. I'm in Washington, for God's sake, and I feel a sense of chaos, and I'm supposed to be doing something about it. And so I think that the idea here is you're supposed to feel helpless. The idea here is there's so much chaos, there's so much going on that you, as an individual citizen, are not supposed to be able to do anything about it. And I think Chuck and I are here to tell you that's not true. Don't panic. In fact, individual advocacy can make a significant difference in the outcome of the legislative process that will get underway on Wednesday, May 7th. So the first thing I might do if I'm listening to this podcast is get onto the National Council for Mental Wellbeing website and click on the advocacy tab of that website to get some information regarding how to contact your legislator. Secondly, I would reach out to the member of Congress that represents you directly, particularly if that member of Congress is a Republican, to indicate your strong opposition to any Medicaid cuts. And it doesn't have to be any more sophisticated than that. Okay. I am a service provider for people with mental illness and addiction disorders. We depend upon Medicaid. Don't screw around with this program. And we'll remember next November if you do. That's all you got to say. Okay. A million years ago, I used to work for a member of Congress. It was when Teddy Roosevelt was in office. And we used to track letters. Now, nowadays, I think they probably track social media site touches and what have you. But I cannot tell you what impact that has on an individual member of Congress. And so if you glean nothing from this podcast, if you do nothing after this podcast ends, that's what we need you to do. Get on the nationalcouncil.org website and reach out to your member of Congress. Look it up, call them, email them, get to the roof of your apartment building or your house or your office building and fire flares in the direction of your member of Congress. They need to hear.
This is metaphorical, audience. He's talking about a metaphor here. You do not go firing flares at anyone. Chuck, you said something earlier, and I want to circle back to this because I think, and I might be misunderstanding this, but I think you said there was a time where we had surprisingly strong bipartisan support for behavioral health.
There is absolutely strong bipartisan support for mental health in Congress. We talk about these potential changes to Medicaid. nobody is coming for us directly, through that, right? It's just that we will be, potentially be a victim, right, of larger changes. So yeah,
We
absolutely.
get caught in the crossfire.
Yeah.
Yeah. So, well, that's good to know, and I think that's good for our audience to know.
So I've been in the mental health addiction treatment advocacy space for 3 decades. I've been a contract lobbyist in this space for almost a quarter century. In almost every bill I've ever introduced, on behalf of the National Council specifically, and then on behalf of virtually all of my other clients, has always had bipartisan support. The reason why that is, these illnesses don't discriminate based upon political party. And so many of our, in the past, Republican champions, but champions on both sides of the aisle, have had their lives touched by mental illness or substance use disorders, and or had their immediate family members touched by these devastating conditions. And so that's helped us with generating support on both sides of it.
Well, I think we all know that yeah, every one of our lives, either directly or indirectly, I mean, we all know somebody who has been affected by this, if not in our own family, then someone fairly close to us. I mean, I think everyone. So your point's well taken, Al. That doesn't go along political lines at all.
So there's no like mental health and addiction specific proposals outside of this annual budget and appropriations process in the Medicaid space. The concern is if significant cuts are made to the Medicaid program across any part of its functioning, almost invariably, there will then be cuts to providers. And then I think in particular, the mental health and addiction treatment providers are vulnerable because every single service provided to a person with a mental illness or addiction treatment disorder in the Medicaid program is optional. Every single one. Rehabilitation option, the targeted case management option, the clinic option. There's a series of waiver programs. They're all optional. And so if a state finds itself in difficult fiscal circumstances, they will either cut provider rates, as Chuck was saying, cut provider rates, or start screwing around with the availability of optional services. I mean, it's just the fiscal reality of it. And then therein lies the anxiety that we confront here now. And then that's why we need the listeners of this podcast to take an activist role in lobbying the Congress on behalf of their patients.
Thank you for providing that insight. I think one of the things that gets me, we hinted at this earlier when we mentioned the word chaos, but it's the unpredictability. It's like, I have sat in on calls with both of you guys when we knew the budget was going south. It was predictable. It wasn't good news, but we could see it coming and you can make accommodations. This administration, it's walking to its own drummer, and it seems like a lot of decisions, they are looking for easy answers to complex questions. And so let's just cut something. Let's just cut the budget. I mean, that's an easy answer, and not realizing that this is a spider web that attaches to all kinds of things. But so we've got, I'm a CEO of a mental health center. I've got some great ideas here from you guys. What should, like, at a more operational level, what do you think CEOs are going to need to do or can do? And frankly, and just because this is Elios, are there technology solutions in any of this for them? Is there something they could do that could that they could take from an operational perspective?
I mean, I think in general, right, any of us who run a business, when faced with these kinds of circumstances, begin to look at, okay, are there programs that are less important, less profitable, less impactful? Do we want to take a look at those? I think that's good. Are there ways that we could be more efficient, more effective? And I think maybe that's where, kind of your suggestion around technology could come in. I know I've had similar conversations with my CTO, right? Could we be using AI more in certain areas in order to reduce some of the burden on staff? So that also makes a lot of sense to me. The hard thing that all of us have to be wrestle with, right, as stewards of organizations like this, how do I make sure that this organization continues to serve its purpose and meet its mission into the future? And sometimes there aren't a lot of good choices coming your way when you have to think about that.
That's exactly right. Uh, I think that rationale, just FYI, that was, my help facilitate a merger of my mental health center with three others, and that what you just said, Chuck, was the underlying proposition. Is my job is to assure the long term survivability so that we can continue to meet our mission. I don't envy my peers who are facing this because there's going to be some tough decisions that have to be made. Al, what you got any suggestions for people? I mean, I think Chuck's were really good ideas.
Here's what I would say, particularly as it relates to AI, because now I've become somewhat familiar with the capabilities of the technology, specifically in the behavioral health space. And I know that we are in the midst of a behavioral health workforce crisis. That behavioral health workforce crisis may get worse if any of the proposals that we've just described here in this hour are enacted. So there is a way, I think, of moving some behavioral health services online, and there's a way of capturing interviews with clients using AI technology that can significantly reduce staff administrative time. And I do believe that may well be an opportunity to address the workforce crisis at the same time as it may well be required to address what could be pressure on the fiscal situation that states and counties will be facing if, in fact, we can't stop some of these Medicaid changes.
I think, like, especially like with Helios and even and NetSmart, they're attacking the problem of documentation overload for clinicians. We're running long. We could go on forever. I want to get one last kind of question in here. What's your best advice? What's one piece of advice you have for our audience going forward as we look at these difficult times ahead?
Well, I liked Al's advice earlier about don't panic. We have an opportunity to weigh in to help shape the future, and we really need everybody. As Al said, we try to make it as easy as possible for you to do that through our Action Center on nationalcouncil.org. I would say do something. Do something.
I dig that, man. I don't know whether I can add anything to what Chuck indicated. And look, here's all I'd say. I've done this for a long, long time. Chuck and I have both done this together for a very, very long time. There is this kind of a cycle here. So we're in the down cycle now, but there will be a dawn. There's oftentimes an opportunity on the upside. And I'm convinced that if we can survive this cycle, there's an opportunity to make some real progress here on the upside. RFK Jr. has a history of addiction disorders himself. If there's a way to talk sense to this guy, there may be a way to actually make some progress at the end.
I love that. I think kind of the takeaway here to the audience is this is a cycle. This is not the end. This is a cycle. Yeah, is it tough? Absolutely. But I love the proactive suggestions. Take action, and particularly with your legislators. With that, I want to say thank you to both of you, Al and Chuck. This has been really great. I want to particularly say thanks to Brooke Andrus, our producer, for helping us get this show on the air. And with that, we will call it a day. Thank you both.